Hello, everyone. My name is Dr. Ashok Agarwal, and I will be your host for the next 2.5 hours. And we are here to welcome you to the next online ART training in Module 5A, which is Overview of IVF and ICSI. Today is Tuesday, May 18, 2021. And this program is made possible by the American Center for Reproductive Medicine at Cleveland Clinic. Again, welcome to everyone. So here we go. This is my short biography. Um, for those who have not attended the previous program, I'm the Director of Andrology at Cleveland Clinic within the Department of Urology. I'm also the Director of Research and very much involved in research in the causes of male infertility. So our program is one of the most active programs looking at the research, focusing our research on causes of male infertility, looking at how we can find solutions that can benefit patients who have male factor infertility. The organizers and the speakers have no conflict of interest. No companies or outside entities were contacted for sponsorship of these events. This program was made entirely possible by the educational support by the American Center for Reproductive Medicine, and the webcasting was supported by David Reichling, David Wolfley from our Information Technology Division at Cleveland Clinic. Thank you to them. The course faculty who you will be hearing today have donated their time for this online training course. Program coordinators you will meet here have volunteered their time for this training. The names, images, and description of products and instruments that you may see in the lectures are used routinely in various laboratories, IVF labs, and these items are not endorsed by the speakers. So today's program, as you have seen, this is called Module 5A, which is basically an overview of in vitro fertilization and intracytoplasmic sperm injection. The program is supposed to complete by noon because it includes the part related to multiple choice. Our lecture component should finish within 2 hours. We have timed it. So the learning objectives today is talks related to essential equipment, supplies, and culture media, protocols for oocyte retrieval, oocyte denudation, and embryo transfer, oocyte characteristics and embryo quality assessment, and important parameters for embryo culture, monitoring, and quality control. In addition, we have 2 more lectures, one by Professor Hassan Salam and one by Kelly Athaije Virka. So these are the components of the today's program that you will see starting from in a circle, starting from equipment to oocyte retrieval, gamete quality, embryo culture, expert commentary, and then industry perspective, and a very brief conclusion. We introduce the next speaker. His name is Dr. Israel Maldonado Rosas. Israel is the owner and chief executive officer of IVF Clinic Sitmer with branches in 3 Mexican cities. He was trained as a clinical embryologist at Instituto Valencio de Infertilidad in Valencia, Spain, a very prestigious IVF institution in Europe, and received additional training at the Cato's Ladies Clinic in Japan, 2 very prestigious institutions. In 2020, Israel was recognized as the Embryologist of the Month by the American College of Embryology. He serves as a visiting faculty in our ART training program when it was allowed to have in-person training at our center in Cleveland Clinic, and he has been doing that for many, many years. So we want to welcome Israel, and now we will have his recorded presentation. Dr. Israel is also actually present today, like all other speakers. So let me start his presentation.
Good morning, everyone. I would like to thank all of you for your time during this presentation. My today's topic is also retrieval, denudation, and embryo loading for transfer. During this lecture, I will cover the following learning objectives, always trying to share with all of you our experience in our IVF clinic. We are going to describe the oocyte retrieval protocol. We are going to talk about the two types of anesthesia commonly used in our clinic, such as general anesthesia and sedation combined with paracervical block. Also, we are going to describe the oocyte denudation protocol. We will talk about the two types of enzymes we commonly use in our clinic to perform the oocyte denudation. I will talk about the correct time to perform the oocyte denudation. I will talk about the embryo loading for transfer protocol. We will describe the two types of embryo loading we normally use in our IVF laboratory, and also the correct volume of culture medium that we need to aspirate into the catheter during the embryo loading. We will talk about the preloading and afterloading methods to prevent any delay due to difficulty encountered during the catheter introduction. Also, I will describe the main parameters from the embryologist point of view that may affect implantation and or pregnancy rate. And finally, we will share with all of you some tips and tricks that I use in order to solve several problems that we can face during our daily IVF procedures. So, for the patient, for the oocyte retrieval protocol, the patient is anesthetized to avoid any pain during the procedure at 36 hours after the ovulation trigger. I would like to mention that when we perform the oocyte retrievals at 37 or 38 hours after the ovulation trigger in order to get more mature oocytes, but more patients got a premature ovulation. So we stop doing it. We normally use two types of anesthesia, such as general anesthesia or sedation combined with paracervical block. We are very careful to assure that both types of anesthesia provide to the patient the necessary comfort to avoid any pain during the oocyte retrieval, especially for the sedation protocol. The oocyte retrieval is performed in our clinic at 120 millimeters of mercury in the vacuum pump. It is important to highlight that negative pressure beyond 200 millimeters of mercury will drastically damage the oocytes. In the meantime, at the IVF laboratory, we search and remove all of the cumulus oocyte complexes from the follicular fluid and wash them in a clean HIPS medium. When the oocyte retrieval finished, I like to remove by dissection only the dark granulosa cells and blood clots from the complexes. And finally, we grade these oocyte corona complexes only in order to check the general maturation status of the cohort. During the oocyte retrieval, our physicians like to combine the sedation protocol with the use of a very thin needle, which is 17 gauge at the base and 20 gauge at the end of the needle, in order to improve the patient comfort during the procedure. We observed that with this strategy, we found the following advantages over the use of the conventional needles, which are 70 gauges along the whole needle. The patient recovers at a faster time after the oocyte retrieval. The pain that the patient experiences decreases during the oocyte retrieval by the help of this thinner needle. The patient may require less analgesia during the procedure because this very thin needle reduces the damage to the ovarian tissue and consequently the pain produced by the needle during the follicular puncture. On the other hand, we also found several disadvantages, which are the following listed in the square located on the right side of this slide. higher risk of needle block due to the reduced inner diameter, especially at the end of the needle. The physicians need more experience due to lower needle visibility on the ultrasound screen. This thinner diameter makes it more difficult to enter into far follicles due to its higher flexibility, and sometimes the needle bends. And finally, the use of this very thin needle makes a little longer the duration of the oocyte retrieval due to its lower internal flow capacity. So for the oocyte retrieval protocol, as you can see on the image located on the left side of this slide, we always try to make it as fast as possible. That's why we like to quickly remove the complexes from the follicular fluid, because remember that a longer duration of this process can produce temperature decreasing in the culture media in 3 or 4 degrees Celsius that can affect the oocyte spindle. And you will see in this video, during the cumulus cell dissection, I also try to save time during this procedure. So quickly, I dissect only the dark granulosa cells and blood clots from the complexes, because these dark cells and blood clots can produce very high levels of ROS in the culture media. I immediately transfer the cumulus-associated complexes to several clean culture medium drops in order to remove the excess of herpes media, and finally to culture them until the insemination time. As you can see here, we like to use the microdrop system due to the many advantages this system provides us during either oocyte or the embryo manipulation. Before the insemination time, we need to determine which insemination procedure will be performed to the oocytes, conventional IVF, ICSI, or only to vitrify the oocytes are the possible techniques. As we know that, for example, for vitrification and ICSI, we need to remove the granulosa cells from the zona pellucida. So for this purpose, I recommend to perform the oocyte denudation 30 minutes before ICSI or before oocyte vitrification. The reason behind this is because the cumulus cells help to introduce or to induce oocyte cytoplasmic maturation, and also help to reduce the oxidative stress produced by the external milieu. For example, changes on the pH of the culture media. But according to my experience, if we perform the ICSI procedure beyond 5 hours after the oocyte retrieval, the oocytes start losing their quality over the time due to the natural process of post-ovulatory oocyte aging, affecting drastically the fertilization, embryo development, and live rates. Remember that the post-ovulatory aged oocytes will face several physiological and morphological changes, such as the zona pellucida hardening, changes on the cytoplasmic appearance, oocyte DNA damage, and finally the cell death. And the only way to stop this apoptosis process of the oocyte is the fertilization by the spermatozoon. Well, we transfer for this denudation protocol, we transfer the cumulus oocyte complexes to the droplet with the diluted enzyme at 10 international units per ml, and start pipetting immediately until we remove most of the granulosa cells by a large inner diameter pipette. So in no more than 20 seconds, we transfer the oocytes to a clean drop of culture media to finish the oocyte clinic using 150 microns stripper pipette, aspirating and releasing several times until we clean completely the oocytes. Remember that the oocyte exposure of more than 1 minute to the enzymes will affect the oocyte quality. I would like to mention that the 2 enzymes we use in our IVF laboratory such as hyaluronic acid, hyaluronidase, or cumulase, both have the same efficacy for removing the granulosa cells, and also both enzymes can work very well in a diluted way, from 80 international units per ml to only 10 international units per ml. After we completed the oocyte cleaning, I like to check immediately the oocyte maturation status under the same stereo microscope located into the laminar flow hood by increasing at maximum the focus and polarizing the light until we observe clearly the presence of a polar body in the perivitellin space on each denuded oocyte. It is always important to try to find sometimes savers or time savers points along the procedure to avoid the drastic decreasing of the culture medium temperature during this procedure that can damage the oocyte skin. Regarding to the diluted enzyme, it is possible to dilute in culture medium both enzymes from 80 international units per ml to only 10 international units per ml. The cumulase, that it is a human recombinant enzyme, or the hyaluronidase that derives from the bovine testicles without compromising the clinical results. I always prefer to expose the oocytes to a diluted enzyme. Regarding to the types of enzymes, the cumulus cells have to be removed from the oocyte to permit the easy handling of the oocyte by both holding and injection needles. Brief exposure of the oocytes to diluted hyaluronidase or cumulase will digest easily the hyaluronic acid, which is the main component of the extracellular matrix that holds the cumulus cells together. And the cumulus cells are more easily removed mechanically by pipetting after the exposure to the enzyme. And I like to use hyaluronidase instead of cumulase because hyaluronidase is cheaper, and both enzymes, hyaluronidase and cumulase, provide similar results. For the homemade glass pipette preparation, to prepare the bullet glass pipettes, we place the Pasteur pipette at the tip of the blue column of the frame of a Bunsen burner, and until the glass becomes flexible, we need to pull the pipette and break it until we get the correct inner diameter. So I would like to say that for different reasons, the embryologists sometimes lose their access to the plastic stripper tips. So for this case, it is still important to know that we have or there is a protocol to prepare and use the pulled glass pipettes in order to solve this problem, especially for the new embryologists. After this, we need to compare the inner diameter of this tip between both pulled glass pipettes and stripper tip in order to assure that the inner diameter of the pulled pipette is the correct in order to avoid any mechanical damage to the oocytes during the oocyte denudation process. And again, after the preparation of the culture medium containing 7 microliters of the enzyme to dilute it until 10 international units per ml. So we need to pipette several times, again, using these pulled glass pipettes. So we need to pipette several times the cumulus oocyte complexes in the medium with the enzyme by the use of a large inner diameter pipette, and then use the pulled glass pipette to finish the cleaning of the oocytes. It is important to mention that the pipetting should be performing by the use of both the hand and a plastic valve, never use the mouth. I would like to clarify that I don't try to encourage the embryologists to only use homemade glass pipettes instead of using commercial stripper tips, but I do believe that sometimes it is better to have some alternatives when for some reasons we lost the access to the commercial stripper tips. So for the embryo loading procedure, it is necessary to prepare only one well dish with 1 ml of Pipettes media in both internal and external wells, overlay with oil the media on the certain well on the central well, and culture for 1 hour. Wash the catheter or not if you don't want to don't want to wash the catheter. It is the same. Both systems provide similar results. But in our case, we always wash the catheter and the syringe with Pipettes media from the external well of the dish. Load the catheter with the embryos or embryos selected for transfer, and always try to place a final volume in the catheter with less than 0.7 microliters of the culture media. The optimal duration of the embryo loading until the embryo transfer ranges from 15 to 60 seconds. In an easy embryo transfer, the duration time is normally less than 30 seconds, with higher pregnancy and implantation rates compared to a difficult embryo transfer that normally takes more than 60 seconds. The use of force or the need to change the catheter and the cause of discomfort, pain to the patient, and or the presence of fluid in the catheter can affect the clinical results. For the embryo loading procedure, we can load the embryos directly from the droplets of the culture media, as you can see here in this image of the left side, or to transfer them to another media before embryo loading, as you can see on the image of the right side. Both ways provide similar clinical results. Regarding to the volume of the culture media we need to place in the catheter, I do believe that less volume always is better. That's why I recorded this video, trying to demonstrate all of you that small volumes of culture media can be easily placed in the catheter during the embryo loading. We normally use these two common ways to load the embryos with similar results. Only one phase of culture medium with the embryos, and at the end followed by a small phase of air, or 3 columns of the culture medium and 3 columns of air in the catheter. The maximum volume recommended is 10 microliters into the catheter. Higher volumes of medium may start resulting with the expulsion of the embryos into the vagina. I would like to address that the presence of several air phases in the catheter during the embryo loading is mainly to facilitate both physician and patients the observation of the catheter on the ultrasound screen, but it is not necessary to aspirate big volumes of air in the catheter with only 2-3 millimeters of each air phase in the catheter. Is enough. So as you saw, only 7 microliters of culture media were aspirated when we added or when we performed the 3 columns of culture medium technique, and also less than 5 microliters when we only aspirate one phase of culture medium. About the parameters which may affect implantation and pregnancy rate, the presence of blood in the catheter affects the embryo implantation, but also large volume of the culture media in the catheter may result with expulsion of the embryos to the vagina. the presence of small air bubbles in the catheter doesn't affect the clinical outcomes. So for troubleshooting, tips and tricks, for the scenario 1, egg collection delayed due to an unexpected incident. What do you do? So the solution is the time range from to perform the oocyte collection is between 34 to 36 hours, but in some cases we can perform at 37 if there is an unexpected situation. For the scenario 2, the vacuum pump doesn't work, and neither the vacuum pump that we have as a backup. So the use of a 20 milliliter syringe to continue aspirating the oocytes is a reliable option without affecting the number of oocytes retrieved. The fertilization and implantation rates also remain similar. For the scenario 3, oocytes are not found by the embryologist after the follicular aspiration from a patient with very low number of oocytes. So about the solution, although I can say that although the use of follicular flushing in women with normal ovarian response is not necessary because it doesn't help to increase the number of collected oocytes, but increases significantly the oocyte collection time. In cases of patients with a very low number of follicles during the oocyte retrieval, so the oocyte retrieval is very short, the follicular flushing can be performed, although it is not always successful to increase the number of oocytes collected, and also no evidence exists to discourage this procedure in poor responders. After the embryo transfer, one embryo remains in the catheter. What can you do? So reload the embryo in the catheter and perform a second embryo transfer. This one is not going to affect the clinical results. For the scenario 5, due to the lack of universal consensus for grading the difficulty of an embryo transfer, what can you do when an embryo transfer is not successful? So for the solution, we consider to vitrify the embryos always than transfer them in a damaged cavity. This can be done even if the embryos comes from thawed oocytes. Implementing a previous trial of embryo transfer in all patients can decrease the risk of having difficult embryo transfers. So the take-home message, the grading of cumulus oocyte complexes is still important. The sedation is an alternative option to general anesthesia. Similar results are seen with both hyaluronidase or cumulase. The follicular flushing is rarely helpful to increase the number of oocytes collected. An easy embryo transfer increases the success in ART procedures, and the cervical or endometrial trauma due to difficult embryo transfer may increase the uterine contractions, affecting the implantation rates. That's why it's likely better to vitrify the embryos than transfer them in a damaged cavity. I would like to thank all of my team at Mexico City, and also I would like to thank all of you.
And you can connect with our program. We are posting daily our research activities, large number of research articles. You have free access to all these publications that we are offering. We are also sharing our latest research presented at ACRM, which is American Society for Reproductive Medicine, European Society for Human Reproduction, American Urological Association. Also, you can learn about our research opportunities and ART training, which are online ART training and opportunities to collaborate. You just have to find me on LinkedIn, Ashok Agarwal Cleveland Clinic, and you can send a request to join.